live, okay?
Wow.
4.
Okay.
Everybody have your seatbelts on. We're going to case number 4, 82-year-old woman with...
Yeah. Can you hear us?
Yes, come on. Yes, you're right on.
Okay, we have case number 4 showing up, 82-year-old female who actually has had exertional dyspnea with NYHA class 3. And the story is the same, that she's had a prior AVR with the mosaic valve, and now she has developed a severe stenosis of the bioprosthetic AVR. That was what she had, 23 millimeter mosaic valve. So a good medication there, and you can see the echo. So we have echo findings are there, but we will show you the live echo as we speak. So cath had shown mild non-obstructive CAD, and what you can see is, we'll show you the pictures, that left main had an acute upward takeoff. So we are concerned would be that there would be obstruction of the left main when we are doing the TAVR in this prosthetic valve.
Okay,
so her STS risk mortality was 9.9. So we have the surgeon here, Gilbert Tang. Heart team discussion made her high risk, and that is why she's here for TAVR for valve in valve.
So
I see that you have, Jason Kovacic. Jason Kovacic is there.
Yep.
Yes.
Jason, you want to take us through the echo and what you do
Gila
and
Perk
how you
is mic'd
prepared
up.
here?
Gila's
So we have Gila Perk, who is the echocardiographer, who is at the head end, and then we have Minakam, who is the anesthesia. We actually MAC anesthesia right now. Okay, Gila, if you can show us the echo and go through it.
Yeah, so here we see that the patient has severe LVH, normal LV function. We have a look here at the aortic valve. You can see that the leaflets are thickened, and you see there's very turbulent flow. The gradient that we measured under general anesthesia and under transesophageal is a little bit lower than what we had on transthoracic. She has a mean gradient of 44 actually on her transthoracic with a very high velocity. Again, another look at the valve showing calcific leaflets. On her mid-esophageal view, again, LVH, normal LV function, only mild MR. You can see the calcification in the valve on the 3D view of the aortic valve. And again, you see the limited motion of the leaflets. And she has only mild to moderate plaque in her thoracic aorta. So, yeah, she's a good candidate.
So we have Eberhard Grube here, and most everyone here, Eberhard, Raj, everyone here is performing, your entire panel here is performing these types of cases. We never will send a case like this to the OR, that's for sure. We have such a great way. The question is, which valve do you choose for valve in valve, and how do you make those choices? So let's start with Eberhard. What do you do, and how do you make those decisions? Eberhard.
Well, basically, it's, you know, what the size of the valves are. That makes a difference. If the valve is larger than 23, it probably doesn't make a difference whether you use a SAPIEN or a core valve or portico if you want. Or to be fair now, even Symetis. But if you know, the smaller you get, the more you're in favor of a supraannular approach, and I would probably take a supraannular valve then.
Jason, any input about the CT measurements and what kind of, and how you guys are making, you and Dr. Kini and Dr. Sharma and Dr. Tang make decisions?
Good morning, everyone. Let's have the slides back up, and let me take you through the CT measurements. I think some of those questions will become self-evident. The slides back up, please.
Slides, please.
ACT is
Good.
okay.
So just while they're getting the slide, we've seen this. It go forward. Next. Next. Good. So this is what the patient has, this 23 millimeter mosaic valve. Just the important points about this as we go through is that there's no metallic ring around the base of this valve. The only things we can see under fluoro are these 3 islets up the top there that you can see. So that's important for as we're deploying and as we're going to be positioning our valve with relation to those 3 islets. Next slide. So this is actually that we're going to go through all the measurements now. The CT, this is the CT of the aortic annulus. You can see there the mean of the aortic annulus is around 20 millimeters. Area is about 3.1. Perimeter is about 62. Next slide.
Theoretical, you can use.
Next slide. Here you go. So the key points here are that the interpost diameter is about 19.5 or so. The diameter of the pseudoannulus where those posts are marries up with the size of the valve that we'd expect from the surgical op report, being that 23 valve. So everything's lining up nicely. STJ height, STJ diameter, but really the concern with this case is the left main. You can see on those bottom pictures there, the left main has this acute upward vertical takeoff. And if you go through the next slide, you can see here as we superimpose where our valve's going to land, the distance where that valve is going to land to the orifice of the left main is in the order of just a couple of millimeters.
Wow.
So as you know, if you get less than 4 to 6 millimeters for that measurement, we are definitely concerned about the left main becoming occluded as we deploy the valve.
Such an important point here for
Very
everyone.
important. So next slide. Just to our access is very adequate. We've taken the right side for the main access here. Next point. Next slide.
She only have one kidney, or?
So just to line everything up for everybody, as I said, the diameter across this valve is around 19. It's a calcific valve, so we know there's going to be calcification of those prosthetic leaflets. By the traditional sizing chart for the native valve, it certainly lines up with a 23 millimeter Evolut valve. Next slide. And also by this mitral flow, 23, the Medtronic Mosaic, a 23 millimeter Mosaic valve is most appropriate in this stenotic setting for a 23 millimeter Evolut R valve. You can go to the 26, but I think in this case, given the constraints of the anatomy, also this is a stenotic case, it's more appropriate for a 23. Next
So before
slide.
you go to your next slide, do you agree with that valve selection, Raj?
So, yeah, you can, I mean, the hemodynamics are clearly better with supraannular valves.
Right.
When you have a small true ID, which is the case here. So
Right.
I think it's very reasonable to actually go ahead and use the Evolut here. But also, it also depends upon your strategy. So you could also say, I'm going to go ahead and actually tear the leaflet using radio frequency, go ahead and put a balloon expandable valve, and then actually use a high pressure balloon to go ahead and fracture it. So that's the other approach that you can actually take. But I think that this is a very simple, elegant approach.
Eberhard is shaking his head like you're crazy.
I'm glad he's bringing this up because I was waiting for this cracking thing. And I think, why don't we just be a little bit more careful, just say cracking it. You have to have a reason to crack something. Apart from the fact that if you put a valve in and you do have a gradient that's too high, then I think it's quite all right. If you start out, let's crack the valve, I don't see a good reason to do it before you even know what the gradient is.
Mark Reisman?
Yeah, I think in this one, we would probably do the Basilica procedure.
Yeah.
Then about 15 of them now, and basically...
Explain the Basilica procedure,
Basically, you place an electrified wire into the left coronary cusp, you cross into the left ventricle, and then you snare it, and then you literally pull it back out, and you cut the leaflet, almost like opening
Which is what Raj is talking
Which
about.
Raj is, it's really quite elegant. Danny DeVere developed it, and I've been fortunate enough to work with him on a bunch of these cases. In terms of valve selection, I think the comments I would agree with.
You're good, and you're good. What do you think about that, Jason and Dr. Sharma, Dr. Kinney? This Basilica procedure, I know we haven't done it at Mount Sinai. Are you considering it?
Just while we're talking, put the fluoro up, please. Yeah, certainly I totally agree it's a consideration in this case. We were greatly reassured by this aortogram here, which I think was more reassuring than the CT itself, that there does appear to be a fairly generous amount of space around that left side and that left sinus for the leaflet and the left main. So this was very reassuring to us. Fully agree that...
and even the Jack article with the Basilica procedure still was associated with some complications. So if you don't need it, don't do it. That's simple. So now we are ready. We actually say we have put a stent in the left main with a guide liner.
Yeah, we have a guide liner with a stent.
And I
which
think
is
the
a
guide
fluoro.
liner here is a very smart move in protecting it as well.
And
So
I
if
think in your
we have the
paper you
Evolut valve, then you definitely need the guide liner. If you are using the SAPIEN, you do not need the guide liner if you are protecting the left main. So we're going up all the way.
So
Hold
you're
on.
really ready to go here
Yeah.
to if there
I think
should
it's-
something happen.
it's a
It's
highly-
really a very, very smart procedure. You wrote about it in the JAC in your JACC paper about how to approach the coronaries during TAVR or after TAVR. Is this exactly how you do this, Paul?
For TBT.
We might crack the valve first, though.
You might crack the valve.
Do PCR after TAVR. And that's
You know, Roxanne, the problem with this valve, especially with the mosaic, even if you don't occlude acutely, you still have cases where they
Ready.
occluded
Hold on, Sine.
later on, the day after, 3 days after. So it's a tricky situation. If everything goes fine, it's fine. But you
Okay,
cannot
start pacing
guarantee.
150.
So you're deploying the valve. I see how everyone's
Raj,
working together.
I-
A couple of years ago, it was like a big deal. Now these guys are doing this in their sleep.
Stop pacing.
So you want to tell us what you're doing, how you're deploying this, especially with a valve in
No,
valve?
the valve came up. I think you should do it again.
No, look.
Recapture.
It looks okay.
You're right.
Parallax and take a picture.
No, take a parallax out.
Yeah.
Okay.
Everyone like that position? I think
I
it's a
think it looks
little...
okay.
Okay, we're taking a picture
Okay,
to see whether
the
it's
thing here
good or
feels
not.
like it looks good.
Inject.
I have a question for Raj.
Looking good?
No, it's good. It's good, actually.
Yeah, I think it'll work.
Do you think that the Symetis valve in this
forward.
situation has more
pigtail out.
chance to
Leaving
keep
everything out there.
the leaflet of the
I have
mosaic
to pull the
down?
guideliner out.
I mean, it seems like that I've not used the Symetis valve since it's not available in the US.
No,
But I
no
would
need,
think
no
that
need,
since
no
you're
need.
keeping
Leave
the
it.
So
Okay.
the question from the panel is the Symetis valve, whether or not this could be a preferable valve in a case like
120
this.
pacing.
Is that what you're
Yeah,
asking?
because the way
Because
that
of the way it works.
is designed, they may keep the leaflet of the other valve down, preventing from coming up. I don't know. I would like to
Can
know
the factoid
if
people
someone
put
did
up
a
the
model.
Symetis valve up
It's
here
something
for
that
us
you
so
can
everyone
check in a
can see?
model.
Samin, can you explain why the guideliner's been pulled back?
Guideliner.
What's the nose cone on the edge of the valve? Because it's infolded a little bit
Yeah.
where that nose cone is.
Wire.
Yeah, the wire's back.
Okay,
there.
good. Pacing off.
Okay, so the valve is deployed. It looks good.
We don't know yet. Let's see.
Well, it looked good when you took a picture before.
I like the optimism. It looks good. On
Okay,
fluoro,
ready?
we
No,
decide.
Are you ready for the left main?
Okay,
Left main.
yeah, for this, yeah.
Important to see what that
Further
left
back.
main looks like.
I think left main looks good.
Yeah, but
Just take out everything.
What does
Okay,
everyone
let's
on the
do a pigtail.
panel? Do you agree
need
to
to
take
post.
things out or
Post
wait?
Before we pull stuff
See,
out.
Okay,
It looks
ready?
infolded.
I think it looks okay, but Give him a good I'd like to see
Inject
that
the
guideliner
pigtail.
down a little further.
At the osteum where
But the base looks infolded to that valve.
fell quite easily.
Okay.
Would you do with the
22 or what?
guideliner or just leave it down?
20.
It looked like
You
one
might
of
have
the
I take out the left main stent.
No, leave it. Okay.
Okay, good. We're coming
Any
out next.
comments from the
Okay,
panel?
So
now
I think
can
that
tell
it would
you
be
what we
good
can-
to measure the gradients,
Everything was
right?
same.
And if you have some gradient and if you decide to post-dilate,
Yeah,
you
it
still
looks
want
like
to
you
have the
need
left
some
main stent there.
post-dilatation. No,
I mean, we don't
you
know.
think, or
We
you
should
don't
measure the
know?
gradients and then
You need the
decide.
gradient.
Okay, post dilation, please.
No, well, first let's see the gradient is what the panel wants to
No, but
see.
I
No,
think
no,
we
please.
still have to dilate
Yeah.
again, you know.
You feel like you need to dilate.
Because
Exactly.
What's the reason for that?
Yeah, see that?
What,
It's
they
not
want to know,
expanded.
why do you feel like you need to post-dilate without knowing what your gradient is up front?
If you look at the inflow on the ventricular side, it looks a little bit constrained there.
Yeah, see that? Lower portion?
Yeah, we saw the lower portion. You see that? That side, but is that really how you would choose? Maybe not important.
Physiology rules.
More ventricular.
Deep. Watch wide.
Yeah.
It's,
And after this dilatation, you see the left main is
You
still
wanna
looking
come
good.
here, you
So
could
then
sit
you'll be ready for your the morning break, your coffee.
No, but we want to see this to the end, sorry.
Okay. No, but a lot of things are there. Yeah, I know, holding.
Yes.
You didn't
why-
have
see
good
the wire
espresso
coming back.
machines. Next year, I want espresso machines here.
Good. Yeah, we'll get espresso machine on the table, yeah.
Yeah.
Good, that's it. Good.
Okay, so they're post-dilating.
Yes, I mean,
Then
what
you'll cut the brake out.
Yeah.
Don't
Pace
ask for
carefully.
those things.
180, yeah.
Pacing.
What size balloons, Samin?
What's the size of the balloon?
and what
20
balloon?
ZMAT 2.
20 ZMAT 2.
Would have been now.
So you decided to use a
Okay,
Z-med
are we
and not a
pacing?
high pressure.
Okay, good. 180, go.
So you have to pace then with us?
Yes.
Yes.
Now you
Why don't
see
you
that
use a true
constriction
balloon?
was gone?
True flow.
Would you use True Flow here?
Yes.
I wanted to
Why can't they show the hemodynamics?
No, they can show.
Just wait till it's on.
We're still pacing.
Okay, continue
off.
pacing. Very important. You don't pull and stop pacing.
Yeah, really, what are you
That would be
pacing
good
so
to
much?
stop pacing. Yeah.
Good. Now we are stopped. Good.
Okay,
And
now
then
let's
do
check
another
the left
angio.
vein.
Let's do
I
the left
think
vein.
a lot of people
Okay,
are
ready.
concerned that
Wait, left vein.
you can move the valve, but the
Ready?
balloon was.
Yes.
So the key is not to stop it prematurely, but I think we had a lot.
Can
of
you
that.
speak
Oh, good.
louder? Because we can't hear
The
you.
leaflet
I
has not
can't hear
affected the left main.
Yeah.
With that note, if everybody is happy,
think
we are done here.
What Anu was trying to do is make sure that there's
Yeah.
enough time so that a lot of times the valve can come up with the
Yeah.
balloon
Right.
if you stop the pacing prematurely.
Yeah.
So I think
I
that's
see.
what-
So the
that was the
longer,
idea.
That you
longer
got to-
duration
especially
of
when you're
pacing was to make
post-dilating, you
sure
need
it
a
doesn't
longer
jump up.
pacing run.
Yeah.
You got to wait for the balloon to completely deflate.
Yeah.
Otherwise, the valve will pop out with you.
So the question was, why we're post-dilating? It's not for paravalvular leak or anything like that. This is patient has prosthetic aortic stenosis. So our rationale is that a gentle dilatation to the waist of the alveolar arch or the ID of the surgical valve will give you more frame expansion and improve the hemodynamics.
You saw that, right? When we were
Yeah.
post-dilating,
And you
there
can
was
see here.
frame expansion.
The frame did expand on the LVOT side.
Yeah, I think it came up nicely.
Yeah.
Okay, are we showing the hemos?
We're
So
not
just
quite ready
show
to
us the
crack valve yet.
hemodynamics.
Oh, no,
Look,
didn't
you saw the
capture.
difference, right?
Looks like you still have some gradient there.
No, hold on. This
Hold
is
on.
just flushing and re-zeroing everything. There's no gradient.
All right, well,
Good.
you have to convince us of that with
Okay,
better
take
hemodynamics.
out the red. Okay,
Ah,
now, see that?
Now we go. Now we see it. Very nice.
Very nice.
Beautiful. Very, very nice case. Thank you all.
All
Thank
right.
you very much.
Ready for your
Thank
break?
you to this incredible
We are
panel.
on. Yeah, we are.
So let me